Chapter 7, Femur and Pelvic Girdle. You have your hip and proximal femur, the pelvic girdle. Your joints are your sacroiliac joints, hip joint, symphysis pubis. You have your femur, of course your lower leg and your foot. The proximal femur consists of head, neck, greater trochanter, that's the anterior portion, the fovea capitis, greater trochanter, intertrochanteric crest, your lesser trochanter, in your shaft or body. That represents the posterior side. Then you have your angles of the proximal femur. From the neck to shaft is about a 125-degree angle. Your longitudinal angle is about 10 degrees. And then your anterior angle is about 15 to 20 degrees. Your pelvis, you have your two hip bones, also known as the ossa coxae, and your innominate bones. You have one sacrum and one coccyx. Hip bone consists of three parts. First part is your ilium. Next is your pubis. And then you have your ischium. And they all join together, all three of them join together to form the acetabulum. The ilium consists of the iliac crest, the ala or wing, body, posterior superior iliac spine, the PSIS, posterior inferior iliac spine, again, acetabulum, anterior inferior iliac spine, and then, of course, your as is, your anterior superior iliac spine. Please look in your book. This picture actually corresponds with page 266 in your book. Know all of this anatomy. Here it is again. This is actually picture 7.7. This is the ischium in your book on page 266. The anterior and posterior portion, this would actually be a lateral view. You have the upper body, your acetabulum, ramus, lower body, ischial tuberosity, lesser sciatic notch, ischial spine, and greater sciatic notch. Here's a picture of the pubis or pubic bone. You have your symphysis pubis, ischial spine, obturator foramina right there. Your body, your superior ramus, inferior ramus, and there's the foramen again. Bony landmarks of the pelvis. You have your iliac crest, top of your crest, your anterior superior iliac spine, symphysis pubis, your ischial tuberosity, and then of course your greater trochanter. Then you have what's called the true and false pelvis, the greater or false pelvis. Here's the brim of the pelvis, and then here's your lesser or true pelvis. Then it goes into the birth canal. Here you have a picture of the inlet and then of course the outlet, plane of the inlet, the cavity, plane of the outlet, coccyx. Again, this is the birth canal. This is on page 267. You can read more about that. This is also another picture of the birth canal, just front and side views. Then you have your gender differences of the pelvis. You can tell on any radiograph, like I always tell people, you should automatically look for things that you can point out very easily to tell what is a male, what is a female, what's right, what's left. And three of those differences are the general shape of the pelvis, the angle of the pubic arch, and the shape of the inlet. So on a female pelvis, the general shape is wider. The angle of the pubic arch is 90 degrees or greater. And then the shape of the inlet is more oval. For the male, the general shape is more narrow. The angle of the pubic arch is less than 90 degrees. And then the shape of the inlet is more round, more circular instead of oval. So here, look at the two pictures and identify the male and the female. Obviously, here we have some lead, so that was a dead giveaway. That is a male pelvis. But if we look at all of those three characteristics, we know that it's a female because it's wider, the inlet is more oval, and the main thing is right here, that angle is more than 90 degrees. Then we look here, if we didn't have the lead there, we could tell that this is less than 90. So that would be female is A, B is male. Here we are with the anatomy that we normally go over together. Make sure you know all anatomy of the pelvis. You know that when I give my tests, I use pictures that you have already seen. So every picture in this chapter is fair game. I would highly recommend you go over every single one. Here you have your axial-lateral projection. Know all of the anatomy. Here, this is on page 269. Anatomy is just a drawing though. Still just gives you a different view. Know the anatomy. Then you have your sacroiliac and symphysis pubic joints, coronal view and transverse section. Here's your sacroiliac joint, and then your sacrum, your ilium, interpubic disc, and then your symphysis pubis. Then you have your joints of the pelvis. You have two sacroiliac joints, the union of the acetabulum, you have two of those. Hip joints, you have two. Symphysis pubis, you have one. The sacroiliac is synovial, amphiarthroidal, and the type of movement is limited. For your hip, you have the classification is synovial, mobility type is diarthroidal and spheroidal. Symphysis pubis is cartilaginous, amphiarthroidal, and limited. And the union of the acetabulum is cartilaginous and synarthroidal and immovable. So now we go straight into the hip localization methods. These are very important. And these are always my go-to when we always talk about topographic landmarks. This is exactly what you need to know. Every time I get a patient, I tell you guys, I go out, I meet them, probably never seen them before in my life, but from the moment I lay eyes on them, I start sizing them up, as I say. I start thinking, how exactly am I going to obtain this x-ray? So this is on page 271. I suggest reading it in detail. Basically, it's telling you exactly where you can find the head of the femur, the neck of the femur. And these are important when you're doing the hip. And again, if a person is obese, if they have a pannus and you just can't palpate, you should know these basic measurements or these basic rules of how to find the head and the neck of the femur. Method 1, to find the head. It is 1.5 inches distal and at right angles to the midpoint of this line. So here's the line. And then here, method 2 will be 1 inch medial and 3 to 4 inches distal to the as is. Now that's going to be the neck. Okay. So again, this is on page 271. Read it in very, very close detail. And this is one of those things that, as soon as you learn it and then you go to clinical, you start implementing it, it will stay with you forever. And anatomy doesn't change. So it's not something that should vary a lot from patient to patient. Here's another picture. This is also in your book on page 271. Just giving you an example. Then you have your anatomic position, true AP of knee, leg, ankle, not the hip. So when you are taking a picture of a true AP projection, the neck of the femur is now parallel to the image surface and will not appear foreshortened. The lesser trochanter is key in determining the correct leg and foot position. If the leg is rotated internally a full 15 to 20 degrees, the lesser trochanter is usually not visible. and is obscured by the shaft. So I know that this patient's feet are straight up and down, not turned in, because I can see the trochanters. And here is the angle from the side. So then you have your internal versus external rotation. Internal rotation, again, when you have that foot turned 15 to 20 degrees, you're not going to see the lesser trochanter at all. If the foot is straight up and down, you're going to see it as we saw it in the picture before. If you rotate the foot, or and the right hip and leg are completely external, you're going to see the entire lesser trochanter in profile. So anatomic position, lesser trochanters are visible. Right here, the feet are up and down. External rotation, that's the relaxed position. They are in profile. You can see them. And then true AP projection, lesser trochanters are not visible. 15 to 20 degrees internal rotation. Asymmetric hip rotation, sometimes when they're looking for a hip fracture. The affected limb with the lesser trochanter in profile. Then you have your male gonadal shield. Most clinical sites don't use these because it's not hard. They're not hard to use, but sometimes it's just not worth potentially clipping off anatomy and having to reshoot the patient to use it. And with the advancement of technology, they have reduced patient exposure so much that a lot of people just don't use them anymore. So this is a small contact shield. It's the top border at the inferior margin of the symphysis pubis for a male. And this is abdominal and pelvic shielding. This is if they are taking a picture of the hip. A lot of people don't use it because, again, you can cut off anatomy that the radiologist wants to see. But it should be available and can be used. Here's another one for the ovarian shield for hips and proximal femora. Depends on what you're looking at. You can shield the patient, but again, you take the risk of cutting off important anatomy, so a lot of people just don't use it. All right, then we go straight into positioning. So here you have your AP mid and distal femur. You're going to rotate the leg internally 5 degrees, CR to the midpoint of the IR. SID is 40 inches. You're going to be using a 14 by 17. Mass is 5 to 10, and your KVP is 75 to 85. What will you see? The knee joint included, no rotation, using optimal exposure factors. Then we go into the lateral, mid and distal femur. They're going to be in true lateral, CR to the midpoint of the IR. SID is 40 inches, using a 14 by 17 IR. KVP is 75 to 85, and your mass is 5 to 10. Patient's going to be in true lateral. You're going to flex the knee approximately 45 degrees, the patient on affected side. Here is an example of the trauma lateral medial, mid and distal femur. Obviously, with the trauma, you're not going to lay them on their side or barely move them. So you have to get a cross table projection. And what will you see? The knee joint included, no rotation, using optimal exposure factors. Then we're going to move into the lateral and mid proximal femur. Proximal femur not superimposed. True lateral, using optimal exposure factors. SID is 40 inches, using a 14 by 17 IR. KV is 75 to 85, and your mass is 5 to 10. Going to flex that knee about 45 degrees and adjust the IR to include the hip joint. CR is perpendicular to the femur, to the midpoint of the IR. And then you have your Then we go right into your AP pelvis. You're going to rotate your limbs internally. That's for a non-trauma because, again, if they were a trauma, you wouldn't move them at all. CR midway between level of the as-is and the pubic symphysis. The SID is at 40 inches. 14 by 17 IR crosswise or landscape. Mass is 20 to 30. And your KVP is 80 to 85. If there is no fracture suspected, you're going to internally rotate both lower limbs 15 to 20 degrees. Make sure that the pelvis is not rotated. Make sure your patient is lying flat on their back. How are you going to do that? You're going to touch them. You're going to palpate their as-is. And you as-is on both sides, and make sure that they're equidistant from the table. CR is going to be perpendicular to the IR midway between the level of the as-is and the symphysis pubis. This is approximately 2 inches inferior to the as-is. So this just gives us a little table of the gonadal shielding and the doses and the comparison. So without gonadal shielding, men get 98 and females get 36. With gonadal shielding, men get 68 and females get 28. So there is a benefit to doing it. Again, with the advancement in technology and the probability of not reshooting the patient, a lot of places just choose not to do it. So what will you see when you film the entire AP pelvis? The entire pelvis and proximal femora included, no rotation of the pelvis, lesser trochanters not visible, using optimal exposure factors. That takes us right into your AP bilateral frog leg projection. A lot of places don't use this. Mostly in the peds department, they will do these. Some ortho clinics do it because they want to have both on one or both hips or hip flexors on one film for comparison. But what you'll do, you abduct the femora 40 to 45 degrees, CR 3 inches below the level of the as-is, and then you have a 20 to 30 degree abduction, less distortion on the femoral neck. Here's what it looks like. Your pelvic girdle is centered horizontally, no rotation of pelvis, lesser trochanters equal in size, greater trochanters superimposed over the femoral neck, using optimal exposure factors. We have your AP axial outlet projection, your Taylor method. The CR is 20 to 35 cephalad for males, 30 to 45 degrees cephalad for females. CR is centered 1 to 2 inches distal to the symphysis pubis. This is a special trauma projection. Evaluation criteria, the AP axial outlet projection of the pelvis. You should see elongated and magnified pubic and ischial bones, no rotation of the pelvis, pubic and ischial bones centered to the collimation field using optimal exposure factors. Next, you have the AP axial inlet projection. The CR is 40 degrees caudal at the level of the as-is. And what will you see? Ischial spines demonstrated and equal, pelvic inlet centered, lateral collimation evident, using optimal exposure factors. Next, we have your posterior oblique acetabulum or Judet method. The CR is 2 inches distal to the upside of the as-is. And then again for the other, the CR is 2 inches distal and medial to the downside of the as-is. Usually this is done in like a trauma situation. It's done a lot at the trauma hospital. And a lot of times they specify which side they want, but then they'll order both sides for comparison. So you have your RPO and LPO. The LPO is the upside, the RPO is the downside. Posterior rim and anterior ilioischial column demonstrated. And then for the RPO downside, you have your anterior rim and posterior ilioischial column demonstrated. You have your PA axial oblique projection acetabulum, the two-fold method, 35 to 40 degrees anterior oblique, 12 degrees cephalad angle, 1 inch superior to the downside greater trochanter. Here is how that looks. You're actually looking at this space right here. Then we go into the hip. This is on page 285. Your hip and proximal femur, your AP unilateral hip. The CR is perpendicular to the mid-femoral neck. Definitely make reference to your topographic landmarks and how to identify where they are on a patient. So you are at 40 inches SID using a 10 by 12 IR. KV is 80 to 85. Your mass is 10 to 20. Your mass is 10 to 20. Going to locate the femoral neck, ensure that there's no rotation of the pelvis, and rotate the affected leg internally 15 to 20 degrees. The CR is perpendicular to the femoral neck. What will you see? The proximal 1/3 of the femur included, hip joint space and acetabulum visualized, lesser trochanter not visible or only slightly visible, total existing orthopedic prosthesis demonstrated, and using optimal exposure factors. Now, when you're in an ortho office and they have a hip replacement, a knee replacement, all of that, that's what the total existing orthopedic prosthesis means. You want to make sure that you include every piece of that replacement on your film. Then you have your axiolateral, your inferior superior Danlius-Miller method. The CR is perpendicular to the mid-femoral neck. This is a mandatory checkoff for graduation. Obviously, we cannot do this in lab, but it's extremely important. This is also termed a cross-table lateral hip. And if you look at your checkoff sheet, like I said, it is a mandatory. So this is something that you will have to do in order to graduate. What will you see? The entire femoral head, neck, and acetabulum visualized, no visible grid lines, optimal exposure factors, a compensating filter recommended. So this was actually taken with regular film, and I can tell it simply because of how it looks. Digital is going to look a bit different. And here, this is what we were talking about with the prosthesis, the ortho prosthesis. You want to include everything. So they included the entire joint all the way down to the bottom of the prosthesis. Cross-table lateral hip or axiolateral hip. This is what that is. Then you have your unilateral frog leg projection, your modified Cleaves method. You're going to abduct your femur 45 degrees from vertical for best demonstration of the femoral head and acetabulum. Abduct femur 90 degrees from vertical. And then your CR is perpendicular to the mid-femoral neck. You're at 40 inches. Your IR is a 10 by 12 crosswise or landscape. Your mass is 10 to 20. And your KV is 80 to 85. Going to shield the patient if you can. Flex knee and hip on affected side. Femur abducted 45 degrees from vertical. Center the affected femoral neck to the CR and the IR. The CR is perpendicular to the IR at the mid-femoral neck. And this actually has breathing instructions. You're going to hold your breath. And I also missed that on the AP unilateral hip. Going to hold your breath, okay? What will you see? The entire femoral head, neck, and trochanters centered to the IR. Femoral head and neck in profile using optimal exposure factors. And here's that picture. A 45-degree abduction, 20 to 30 abduction, less distortion of the femoral neck. And everywhere you go, people are going to do it a little different. Some people are really, really strict about the 45, and then some do about 20 to 30. Then here's a modified axiolateral or Clements Nakayama method. The CR is 30 to 40 degrees mediolateral and 15 to 20 degrees posteriorly from horizontal. CR is centered to the femoral neck. And what will you see? The entire femoral head, neck, and trochanter centered to the IR, femoral head and neck in profile using optimal exposure factors. Of course, the Clements Nakayama method was probably going to be used in a trauma situation where you can't maneuver the patient. Next, we have your radiographs for critique. I'm not going to go over these in detail because these are the pictures that you will use for your assignment, and I need you to look over them, think them through, and come up with what you think is going on your own. So I'm just going to click through these very quickly. All right, up next is pathology. Pathology you can find on page 274 and 275. First one is ankylosing spondylitis. From the book, it says the first effect demonstrated is fusion of the sacroiliac joints. The disease causes extensive calcification of the anterior longitudinal ligament of the spinal column. It is progressive, working up the vertebral column and creating a radiographic characteristic known as bamboo spine. Males are most often affected. And here you go. You can see the fusion. Looks like a bamboo. Then you have what's called an avulsion. These fractures cause extreme pain and are difficult to diagnose if not imaged properly. Fractures occur in adolescent athletes who experience sudden, forceful, or unbalanced contraction of the tendinitis and muscular attachments, such as like when they're running hurdles. Okay, that's an avulsion fracture. Then you have your chondrosarcoma. That's a malignant tumor of the cartilage. It's usually in the pelvis and long bones of men older than 45. It may be completely removed surgically if it does not respond to radiation or chemotherapy. Chondrosarcoma. Then we have osteoarthritis. It's a condition also known as degenerative joint disease. And this is where you have degeneration of the joint cartilage and adjacent bone causing pain and stiffness. Right here. And most times when you x-ray a person like that, it comes up bright white like that because it's really broken down and it's kind of gotten hard there where that's where they're having the pain. It's like inflamed. Then of course you have your femur fracture. Obviously your femur is broken right there. And then you have your metastatic carcinoma. The malignancy spreads to the bone via the circulatory system or lymphatic system or by direct invasion. Metastatic tumors of the bone are much more common than primary malignancies, and bones that contain red bone marrow are the more common metastatic sites, like your spine, skull, ribs, pelvis, and femora. Then you have the developmental dysplasia of the hip. These are hip dislocations caused by conditions present at birth and may require frequent hip radiographs. Developmental dysplasia of the hip.